Hi, this is Dr. Haile. I'm an orthopedic surgeon who does primarily hip and knee replacements, along with my PA, Jessica Chestnut.
Hi, I'm Jessica. I'm a PA that works with Dr. Haile and assists him in the OR.
For our case today, we've got a 75-year-old female who has significant hip arthritis, and she's here for a total hip replacement. The primary reason for total hip replacement is arthritis, in which case most patients have bone-on-bone arthritis. If that's the case and it's painful and the patient is unable to do the types of things they like, a total hip replacement can be life-changing in the relief that it provides. It can also help you get back to doing all the things you love to do. The patient here has a long history of right hip pain, and her x-rays are shown. One of the really cool parts about the way we do hip replacement is this planning process. The green line shows the stem that goes into the femur, and the blue line shows the socket portion. You see various lines drawn on the screen that show several things. One, it shows the way the patient stands up, and it shows how her bony anatomy sits in place when she's standing. This is really important because it helps us match the position of the x-ray machine that we'll use in surgery to recreate the way the patient stands. And that helps us individually put in the components in the exact right position for each individual patient. Another thing you'll notice is that this patient has a leg length inequality. This is a really common part of doing hip replacement, and what it means is that one leg is shorter than the other. That happens because as hip arthritis develops, the cartilage is worn away and the leg shortens within the socket. This arrow that you see shows that the red line on the screen goes through the middle of the lesser trochanter, which is the small bump on the side of the femur. On the right, it passes through the middle portion of the lesser trochanter, and on the left, it passes higher up, which shows the 5 millimeter leg length inequality. The yellow letters on the side of the screen are notes to me that helps us do the surgery in the correct way. This is a shot of us in surgery. You'll notice that the patient is lying on her back, which is different than a lot of hip replacements. We perform a direct anterior approach, which means we make an incision on the front of the hip. This approach offers several advantages, one of which is a quicker recovery. Another advantage is the ability to judge leg length at the end of surgery, as you'll see a little bit later. You can also see that both feet are prepped into the surgery, and this allows us to physically check the leg length. There are other additional benefits, including that this is a muscle-sparing approach, so no muscles are actually cut, and also there's a decreased risk of dislocation. Now that we have excellent visualization, we can begin the process of reaming the acetabulum. The end of this machine is round in a semicircular fashion, good shot there, and it's shaped like a cheese grater. The purpose of this is to remove the hard bone from out of the acetabulum for the component to be placed into. Now that the component, or the part, has been placed, we bring in the x-ray machine, which is then positioned and adjusted to match the patient's standing position. After we make the initial adjustments, we use the device, the grid, to make sure that the component is in the correct position. After this metal portion of the acetabular component has been impacted into place, we put in a plastic liner which snaps into the metal part, and we move on to preparation of the femur, or the leg bone. Here's a quick shot of the setup that shows all the parts and pieces that are required to do the hip replacement. This is a testament to the team that I work with, which, as you can see, are several in this shot, and each one of these people is vital to completion of the surgery. In this frame, you can see the preparation of the femur. What we'll do is use subsequently increasing sizes of broaches to help create the correct pathway in the femur for the correct size stem. You can see that the patient has her right leg crossed under the left leg, which enables us to perform the direct anterior approach total hip arthroplasty without the use of a special table. This is another benefit of having both legs draped in addition to being able to check the leg length at the end of the case, as you can see us doing so here.
Part of my job in this case is to dislocate and reduce the hip when checking for leg length and stability. You can see in this shot, I do the initial check for leg length, and then Dr. Haile confirms this finding.
And then we use x-ray to make sure the stem is the appropriate size. And then we remove all the trials and put in the final implants. At this point, we've placed the final femoral stem, and coming into the shot now is the femoral head, which will then be impacted onto the top of the stem. After it's impacted into place, Jessica will reduce the hip. We again check the leg length and move on to the closure.
For the closure, we do about 4 to 5 layers of sutures, starting deep at the capsule and working our way up to the skin. In most cases, we are able to do all of the sutures under the skin so that nothing needs to be removed at the post-operative visits.
We take great care in maintaining the anatomy and placing the prosthetic components in the same position as the patient's native anatomy, which leads to quicker recovery and overall better function. At the completion of surgery, we begin the post-operative care. Most people have many questions about post-operative care, and there are many misconceptions which we'll try to diffuse here. By doing the anterior approach, we're able to avoid any limitation in the way you move your hip in space. There are typically no precautions, no weight-bearing restrictions, and no limitation on how you sleep, how you stand, or how you sit. There is some pain, as with any surgery, which typically lasts a few weeks. But by 6 weeks, we expect most patients to be better off than they were before the surgery. In fact, patients with severe hip arthritis tend to improve the most quickly.
Following the closure, we put a bandage on that does not need to be changed for 2 weeks. Patients come back at 2 weeks post-operatively and then again at 6 weeks post-operatively. At the 2-week follow-up, we remove the bandage and check the incision. At the 6-week follow-up, we do another x-ray to ensure that everything has gone well. After that, the next follow-up is typically at 1 year. While some patients do benefit from physical therapy, most of our total hip replacement patients can do their physical therapy at home through an app-based home exercise program. If needed, at the 2-week post-operative appointment, we can discuss pursuing outpatient physical therapy, though most patients do not need to do so.
Overall, hip replacement is a fantastic option and is able to benefit patients who are struggling with hip arthritis and hip pain. It's a great choice for these debilitated patients. I hope you've enjoyed our video, and we look forward to seeing you in clinic. Thanks a lot.